For those of you just logging on, we're just giving a few seconds for people to log in. Okay, well, let's go ahead and get started. Good evening, everybody, and thank you for joining us for our virtual community lecture this evening, focusing on spine health. My name is Catrice Nakamura. I'm the director of the Neuroscience and Stroke Program here at Little Company of Mary. And we're joined by two surgeons from our Spine Institute tonight, Dr. Remi Ajiboye and Dr. Jean-Philippe Langevin. But before we get started, I want to let everyone know that this is a 1 hour long presentation. We'll have plenty of time for questions at the end of both presentations. But you can use the Q&A box to type any questions that come up during the talk. We'll do our best to get to each of the questions at the end, but we will not be opening up for attendees to speak on this webinar. So this lecture is really focusing on the Spine Institute here at Little Company of Mary. For more information about our Spine Institute, you can call 1-888-HEALING. And we're going to also post the URL link to our website that you can go ahead and reference. So now it's my pleasure to get started with our first speaker, Dr. Jean-Philippe Langevin. So Dr. Langevin is a board certified and fellowship trained neurosurgeon specializing in the surgical treatment of movement disorders, epilepsy, and psychiatric conditions. He has extensive experience using neuromodulation to treat conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, and obsessive compulsive disorder. He employs a variety of treatment modalities, including deep brain stimulation, vagal nerve stimulation, and interstitial laser ablation. He's the director of the Restorative Neurosurgery and Deep Brain Stimulation Program at the Pacific Movement Disorders Center. He is also the director of the Neurological Spine Surgery Program at Little Company of Mary, where he employs reconstructive and minimally invasive spine surgery techniques. Without further ado, please welcome Dr. Langevin. Thank you, Dr. Langevin.
Thank you, Catrice, for the introduction, and thank you, everybody, for joining tonight for this presentation. Go ahead and share my screen here. But tonight, we'll be discussing the treatment of neck pain and back pain. My colleague, Dr. Ajiboye, is going to be presenting back pain, and so we'll be starting with treatment of neck pain. And so the different topics that I wanted to cover today were, what are the origin of neck pain? Like, why do people have neck pain anatomically, where it's coming from? Sometimes having an understanding of the pain, it's easier to figure out which treatment would be a better fit for you. I will then go over the different treatment options that currently we offer for neck pain, and we'll discuss more in detail the approach that we employ here at Little Company of Mary at our Spine Institute to surgery for the neck. So the origin of neck pain actually are somewhat complex and mechanical in nature, but they're essentially several tissue deep in the neck area, and all of which can be the source of pain. So it can be a so-called pinched nerve that can cause the neck pain, and typically that's a type of pain that would originate from the neck and then shoot down into the arms, into the head. And then there is more arthritis, or wear and tear type of pain in the neck that's going to be more located in the center portion of the neck without too much radiation into the extremities, but sometimes it can go to the back of the head. So that's this type of pain that sometimes people feel like it's standing towards the back. Cervical instability or fracture, it goes without saying that with a significant accident, people will have a tremendous amount of pain if the structure of the spine is unstable. And just to go over a little bit what it means, we have some representation here of a cervical spine anatomy. And you can see the different structures of the skeleton. So you have the different bones, and in between the bone, we have what we call the disc. And so these discs are essentially they kind of jelly donuts that sit in between the bone, and they allow us to move the neck back and forth, so all the different motions of the neck. And this view here shows a cross section, so taking right through the center of one of the spine as if you're looking down on it. And then we can appreciate again this disc. And I was saying is jelly donut, and that you have the dough on the outside, and then at the center is a jelly essentially inside, like a cushion. And then in the center of the spine, we have all the neural elements, the structures. So the little engine that are making us move in terms of the movement in the arms, the legs. And so on the sides, we have the actual nerves, and in the center, we have the spinal cord. And so all those areas can be responsible for pain. And so this is depicted in this picture. You can see how, like, occasionally those discs that are, as I mentioned, jelly donut, can have some of their jelly squeezing out and causing some compression of the nerve and the neural elements. So in this case, you can see how the dough has essentially ruptured, and the jelly is pushing into what we call the spinal cord. So like the elements in the center of the spine that are responsible for movement. It's not only this can cause a lot of neck pain, but it can also be responsible for loss of dexterity in the hands, difficulty walking, difficulty with using the hands and the arms. Now, when the same disc ruptures slightly off center to a side, then one of the nerve may get pinched. So you can have a pinch of the nerve either on the left side or the right side. And so this will cause pain also in the back of the neck, but typically radiating to one of the extremity, depending on which side the disc is extending to. And finally, we can have the pain can be originating from the different joints or the bone itself. So like sort of like the scaffold of the spine. So that's represented here on the right hand side, where we have multiple small joints throughout the spine. And all those joints normally have structure that's involved with a little bit of fluid inside, like lubricants. But over time, we can have wear and tear, damage, and this causes inflammation. And so that can be the source of pain. And the reason why, I spend a time here to go through this is because the treatment options and the best treatment options are very different if we think the pain is coming from a joint, the bone, the disc, or the nerve getting pinched. So it's important for us as physicians to go, when our patient comes to our clinic, it's important that we sit down, perform, a thorough examination, and at the same time, really a profound history where we discern where we think the pain is coming from, like what we think is the issue at the root cause there behind the pain. And so I list here general treatment options, and we'll go over in detail the majority of them. But when somebody has neck pain and spinal pain in general, these are the treatment options. And the first one that's been recommended in the literature scientifically is exercise therapy. And specifically, some of the exercise that have been shown to be highly beneficial for spinal pain is yoga. And the reason for that is that that's a type of exercise that really focuses on the core musculature of the body. And as you can imagine, it helps the patient improve their posture, and it sort of acts as an internal bracing for the spine. So any of the structures that are being damaged, whether it's the joints, the bone, the disc, or the nerve, if the structure, the internal bracing of the spine is stronger, all of that can help reduce the amount of pain. Physical therapy is an excellent adjunct, and so it's a must. So anytime anyone has neck pain or back pain for an extended period of time, we recommend the use of a thorough physical therapy. And we work closely with our therapists so that we go back and forth oftentimes with the therapist for specific patients, saying like perhaps we should try this modality or this other type of modality to try to target the pain the best way possible. Anti-inflammatory medications, so that's your typical Motrin or ibuprofen and Tylenol over the counter. So those are actually the best ones for spinal pain and essentially the only ones that have shown strong benefits. Injections from pain doctors, and we'll go over that briefly, and alternative therapy. And finally, when everything else fails, surgery is a good option. And so this is some example of some of the therapy I mentioned that we oftentimes go back and forth with our therapists. And the reason for that is because they have an extensive repertoire that's available to them in terms of the treatment options that they can offer their patient. Swimming and aquatherapy those two are up there in terms of exercise, along with yoga and Pilates, depending on the preferences of the patient. So these are all exercises that are really going to focus on the core musculature. Swimming has the added benefit that you're partially supported by the water while you're performing the exercise, so that it can facilitate the movement. And in terms of the hands-on approach of the therapist, so range of motion is something where we can help out with the joint movement and facilitate so those joints where there's a lot of wear and tear to facilitate the movement and reintroduce some fluidity in the movement. Cervical traction is represented here at the bottom right, where some equipment can be released for home use. And the idea there is by stretching the neck, we can release the pressure on the nerves without performing any surgery. So some people call that spinal decompression or traction. Manual therapy and ultrasound therapy is represented at the top right. And so the idea there is really to release the amount of the knots basically in the muscle and relax the fascia, which is the covering of the muscles, to release the tension, and oftentimes that's sufficient to break some vicious cycle where the patient has pain from some degree of arthritis in the neck. And as a result of that, there's a lot of tension in the muscles that form, and that kind of precipitate more pain. And so by addressing the spasm itself, then sometimes it will break that cycle. And electrical stimulation is along the same line, but it can be performed at home with what we call a TENS unit, which is a small patch electrodes that you can attach where the pain is located. We can also refer patients to our colleagues in pain management. They also have several options in their repertoire, including injections around the nerves, as you can tell here on the image. So using longer needle and numbing medication under X-ray guidance, they can inject near nerves or inside an inflamed joint, as you can see here, to reduce the pain. Alternatively, I've had patients who benefited from acupuncture. It seems, in my experience, that it helps a lot of patients who have a fair amount of anxiety or stress in their life as well, and that causes the tension in the muscle. The ultrasound can help, but on occasion, acupuncture is better. Other patients have tried ketamine infusion, as well as CBD oil that are now becoming more available on the market. So then a second topic that I wanted to discuss was surgical treatment, right? So we discussed here multiple lines of therapy. However, if that's not sufficient, surgery is oftentimes the best approach if the pain is resistant to a conservative management. Our approach at Little Company Mary at the Spine Institute is fourfold. So first, we always try to minimize the amount of tissue disruption that's performed during the surgery. So we use so-called minimally invasive approaches, so which means a fancy term meaning a small incision. So smaller incision, smaller scar, smaller tissue disruption means faster recovery and less postoperative pain. Then the second thing that we keep in mind is always, if in our surgical approach, we should focus on motion preservation, meaning like not fusing or not immobilizing a joint of the spine, or if it makes more sense to provide the fusion. So that's the second approach, and whenever possible, our preference is motion preservation, obviously to maintain normal range of motion of the patient postoperatively. Our third focus is on computer guidance and images intraoperatively. And so that's essentially meaning using a GPS. It's a little bit like driving, using GPS to assist you during the surgery. And it makes the procedure more precise, so that if we do end up using implants during the surgery, we know exactly where they fit inside your anatomy, and we know exactly how to size or which implant to select surgically. And we also focus on a multidisciplinary approach for enhanced recovery to minimize the amount of pain postoperatively, and we work closely with our therapists, our nursing staff, for the administration of a multidisciplinary approach for pain control and to help the patient resume normal function postoperatively to facilitate return to home and return to work. So minimally invasive approaches, so more concretely, what we do for that is we use some of smaller equipment. In this case here, it's represented tubular retraction approaches. And so you can see how with using small incision with these fancy retractors, we can get exactly where we need to go on the spine without having to make a large incision and a lot of disruption of the muscle tissue. And so these retractors guide us exactly where we need to be. And they provide us the visualization that we need to perform the surgery to make sure that the structures are free of compression without disrupting the tissue extensively. And oftentimes using this, the patients can even go home the same day after the surgery. And the incisions are typically within 1 inch in size. So that's just an example where we are looking down basically on the cervical spine where somebody has a pinched nerve, and so we're using our tubular retractor, so we're looking straight into the center of the tube, and essentially at the end we're seeing the nerve. They're completely free of compression, and this is all done through an incision that's within 1 inch. And so in this case, this patient could be released to go home from the recovery room immediately. In terms of motion preservation or fusion in the neck, we're talking about artificial disc typically. And so we have some illustrations of our approaches. Again, we focus on tiny, so small incision for cosmetic reasons, but also to facilitate recovery after surgery. And these incisions using our retractors and magnification of microscope or endoscope if needed, we can visualize the spine just as well as if we had a large incision or a large approach. And then, we focus during the procedure at removing the compression on the elements that are compressed. So specifically, we want to make sure that the nerves are free of compression. We want to make sure that the machinery, like the spinal cord that controls the movement, is free of any compression so that the patient can resume normal function after surgery. And then we focus on implants that minimize the amount of profile. So we nowadays, a lot of bioengineering has been put into implants, and so there's been a lot of improvement into the shape, such that it looks very similar to the natural anatomy. So without any profile or plates, or large screws that can cause swallowing difficulties or other problems down the line. And so that's one example of such an implant. And the way they're fixated in place once we do fusion is that when we do use screws, they are essentially without profile, so the screws are not extended at the surface of the spine in the front. They are recessed inside the graft itself, so within the bone, such that at the very end of the surgery, there's nothing essentially that sticks out in the front of the spine. And as I mentioned, our focus is to use artificial disc to maintain the movement of the spine post-operatively. And so that's one example of a disc that we can use that allows to arch back and to flex forward fully the same way a normal disc would have done. And this is a post-operative radiograph of a patient of ours, where you can see that the patient is getting the full extension on the left-hand side and the full flexion, where you can see the disc essentially moving back and forth to allow that motion. And as I mentioned, our decision is multifactorial as to when we decide to use fusion or artificial disc. And it depends where we think the pain is coming from. And on occasion, using a fusion system is better to control pain, and sometimes using the artificial disc whenever possible is a better approach. Just one last slide to discuss computer assistance, so a GPS in the OR. And just kind of illustrates a little bit our approach, where essentially the anatomy of the patient, as well as the instruments that we use in the OR, everything is linked together and by the computer. And so it guides us, precisely. So we know exactly where we are in the patient's anatomy, but also where the implants are going to be inside the anatomy of the bone, essentially at the end of the surgery. And so this type of technology allows us to really focus our surgery using small incision, but also to optimize the size of the implants that we place. And so just in conclusion, the majority of the time, neck pain is treated conservatively. The majority of patients, even if the pain extends into the arms or up towards the head area, we can treat with modalities that are non-surgical, some of which I explained here. If surgery is needed, there are several techniques that we can employ to minimize the pain postoperatively and allow our patients to return quickly to their lives postoperatively. And some of these techniques can also improve long-term outcomes by doing the less to the spine. Then we also stress the spine less, so then the future normal function resume. So that was what I wanted to share today, and I'll give the microphone back to Catrice.
That's great. Thank you, Dr. Langevin. It's really interesting just to learn about alternative treatments instead of surgery, things that are less invasive. So thank you for sharing that. And I'd like to now introduce our next speaker. Our next speaker is Dr. Remi Ajiboye. He's a spine specialist and medical director for the orthopedic spine at Providence Little Company of Mary Medical Center in Torrance. Dr. Ajiboye has advanced fellowship training in minimally invasive spine surgery and spinal reconstruction for conditions involving the cervical, thoracic, and lumbar spine. He completed his graduate studies at UC Berkeley, followed by medical school at UC San Francisco, and an orthopedic surgery residency at UCLA, where he served as chief resident. He then completed a minimally invasive spine surgery and spinal reconstruction fellowship training program at Stanford, where he also served as a clinical instructor. Dr. Ajiboye has a strong interest in new technology and research on minimally invasive ways to treat spine conditions. He's written over 40 research papers and book chapters and presented his work nationally and internationally on spine conditions. Dr. Ajiboye's treatment philosophy is to use the least invasive means possible to help relieve pain and improve a patient's quality of life. Welcome, Dr. Ajiboye.
Thank you for that introduction, Catrice. Can everyone hear me okay?
Yes.
Perfect. So as Catrice mentioned, my name is Remi Ajiboye. I'm a minimally invasive spine surgeon. My talk is going to focus primarily on non-invasive treatment options for back pain. She already mentioned some of my introductions. I won't bore you guys with this, but my practice is primarily twofold. One aspect of it is primarily minimal invasive spine surgery, and the second half of my practice is on complex spinal reconstructions for patients with complex spine conditions like scoliosis or hunchback, or people who've had multiple spine surgeries in the past. I have an office here in Torrance and El Segundo, and as Catrice mentioned, my practice philosophy really is to be as conservative as much as possible, and if surgery is ever needed, minimally invasive is always the way to go. Just a brief anatomy of the spine here. I know some of this was covered earlier, but the spine is made up of several areas. Here's the neck area called the cervical spine, as well as the upper back called the thoracic spine, the lower back called the lumbar spine, the sacrum, and then the tailbone down here called the coccyx. Of all the segments, the lower back is probably the most common area, common source of pain for most patients. Lower back pain is in fact so common that is actually the second reason, only next to common cold, for why patients will visit their primary care doctors. In terms of risk factors for back pain, we actually think vast majority of patients who develop back pain is primarily due to a genetic predisposition. Obviously, we know that certain factors such as being obese or overweight, smoking, being of a male gender, as well as certain jobs that involve a lot of prolonged sit-in, a lot of vibration, certainly can also predispose patients to increased risk of back pain. Now, just brief anatomy of the lumbar spine, which is where the lower back is. I hope you guys can see my pointer here. This is a lumbar MRI. This is what I call a side profile of the lower back on an MRI. So just for orientation here, the front of the spine is here, and then the back of the spine is here. The areas here with the blue letter in is the area called the vertebrae. So these vertebrae are little square-shaped bones, which I like to consider the building block of the spine. In between those square-shaped bones is an area called the disc, which is here in the circle. And the disc is essentially a cushion between the bones. And then the back of the spine, not pictured here, the additional areas in the spine called joints, called facet joints in the back of the spine. And obviously they also surround the muscles and ligaments at the back of the spine as well. All these areas that I just went over can be a source of lower back pain. So for example, this is a patient with what we call a osteoporotic compression fracture, which is just a broken bone from weak vertebrae. So like I said, the vertebrae should have this nice square shape here. However, this is a segment here where a fracture or broken bone is developed, and this is usually because of weakening of the bones. Obviously, this can be a huge source of back pain for people. This is an example of a patient with a disc herniation. So again, remember the disc is the cushion between the bone, these are, for example, the nerves in the spine. So this darker gray area here are the nerves in the spine. The white area is just the normal fluid that surrounds the spine. This is someone with a massive disc herniation, which is essentially taking up all the space available for the nerves. I like to make a distinction. This is a question I oftentimes get from patients is, do I have a disc herniation or is this a disc bulge? The best way to think about a disc herniation is, as alluded to earlier, it's like having a jelly donut, and that donut has a hole in it, and a lot of that disc has now been, the jelly in the inside of the donut has now been squeezed out and is causing significant nerve compression. This is in contrast to having a disc bulge. Having a disc bulge is more like having a little bit of a flat tire. Everyone gets a disc bulge, or much say most people get a disc bulge as we all get older. It's just part of the natural process of aging. Another question that I oftentimes get asked by patients is, what is sciatica? Sciatica just means you have pain that's going on into your legs, typically from a pinched nerve in the lower back. And then stenosis, which a lot of patients see in their MRI reports when they bring to me, stenosis is just a fancy word for nerve pinching. Another common source of back pain is what we call slippage of the actual vertebrae itself. Again, as you can see in this MRI, all these bones in the back of the spine, called the vertebrae, they all line up pretty well together, except for right here. There's a bit of a misstep here where this bone is actually slipped forward relative to this bone. And this can actually call what we call, you can call spinal instability. So every time people go from sitting to standing, the spine essentially almost dislocates out of place, and unfortunately can also pinch the nerve significantly and cause back pain or sciatica down into the legs. In terms of treatment options, our mainstay of treatment for back pain is typically anti-inflammatory medication. Now, these come in two forms. One is a steroidal and one is a non-steroidal. Non-steroidal are things like over-the-counter medications such as ibuprofen or Aleve or naproxen. And while steroidal medications are typically prescribed by your doctor to help bring inflammation down. A common, obviously, cause of back pain itself is inflammation. And the goal is always to bring the inflammation down. Now, obviously, a word of caution is that some of these medications should not be taken by all. It can certainly have side effects. It can sometimes give people stomach ulcers, or if used in the long term, it can actually cause damage to the kidneys. So these are things that should be taken with a doctor's supervision. Alongside anti-inflammatory medications, muscle relaxants can oftentimes be very, very helpful for the treatment of back pain. The idea is that whenever there's inflammation in the spine, it causes the muscles around the spine to tighten up and spasm. And oftentimes these muscle relaxants can be very, very helpful in relaxing those muscle spasms. These medications, unfortunately, can be quite sedated and make people sleepy. So oftentimes tell people take it at night first, and certainly don't take it for the first time, while driving a car, in case it makes you too sleepy. Another class of medications are things called neuropathic medications. These are essentially nerve medications. They're meant to help the nerve heal and recover. Some common examples are things like Neurontin or gabapentin, which people take for leg pain, or sometimes patients with a neuropathy from diabetes could oftentimes take these medications as well. And then the last line of treatment, which oftentimes we like to stay away from, are opioids, right? Because we all know opioids can be quite addictive, and opioids really work not by actually decreasing the level of pain or the cause of pain at the origin of the pain itself. They actually work by essentially tricking the brain to not experience pain symptoms. And so I'm personally not a big fan of opioids, and we try to minimize these. Physical therapy is an absolute mainstay of treatment for back pain. The concept of it is it focuses on stretching and strengthening. The idea is that if you have back pain, there's probably an imbalance between your core muscles in the front of the spine and what we call the paraspinal muscles in the back of the spine. And the goal is to develop what we call dynamic stabilization. Basically, you want to create a balance between these two muscles so that in the long run, they actually take a lot of pressure off the actual spine itself and minimize back pain. As part of physical therapy, things like ultrasound treatments can oftentimes be done, as well as what we call TENS, which are essentially a muscle stimulation devices that can help with the back pain as well. Acupuncture is a personal favorite of mine. I probably prescribe this 10 times a week. And I'll be the first to admit that I do not know 100% how acupuncture works, but I know it works. It's based on the concept of qi, which is the energy flow in the body. And the idea is that when these energy flows are disrupted, it can cause pain. I certainly highly recommend acupuncture to a lot of my patients for back pain. Chiropractic adjustment is another very common one that I oftentimes prescribe. It's based on a lot of soft tissue manipulation and mobilization, some work with traction as well. And this can oftentimes be very helpful for patients as well. Lastly, spinal injections are another option. The whole idea of a spinal injection, what we call an epidural injection or a nerve block, is that you want to deliver a medication directly to the source of pain or the area of pain. And these medications are oftentimes a combination of an anesthetic medication, which is a numbing medication, as well as an anti-inflammatory medication, which is a steroid. These are oftentimes done by our pain management colleagues, and can be really a big help for people, especially with severe pain. A question I oftentimes get asked by patients is there a role for stem cells for management of back pain? while there's a lot of research going on in terms of stem cells, there's currently no role for stem cell in terms of pain relief in the spine. These injections, such as epidurals and the numbing medication, are at least the go-to options we have. Now, if someone has tried all these options and they're still in significant pain, and their symptoms are interfering with their everyday activity, then surgery can be considered. This is a question I oftentimes get asked by patients: is, do I need surgery? And my answer is, most people do not need back surgery or neck surgery. People can consider surgery if their symptoms are severe enough and have done a bunch of other things, and they're not getting symptom relief. Obviously, there's certain exceptions in terms of patients who should probably consider surgery. And these are patients with kind of more concerning type symptoms, such as infections, cancers, people with severe muscle weakness, people with sudden changes in the bowel and bladder function, or people at risk for having severe permanent nerve damage. These are oftentimes patients who will probably nudge to say, listen, you should probably have surgery, this can oftentimes be a matter of life and death, or risk of permanent injury if surgery is not done in a timely manner. If surgery should ever be considered, my personal choice is to be as minimally invasive as possible. And the whole idea of minimally invasive spine surgery compared to traditional open spine surgery is that through smaller incisions, you get reduced blood loss, decreased chance for causing scar, which causes less pain, which leads to shorter hospital stay, and it helps patients get back to their normal activity sooner than the traditional way of doing spine surgery or back surgery. A subset of minimally invasive spine surgery that I'm starting to do more and more of by a little company in Torrance is actually something called awake spine surgery, which at first glance often sounds scary to a lot of patients. But the whole concept of awake spine surgery is that the traditional way of doing spine surgery, I would say probably 99% of spine surgeries are typically done under general anesthesia, which is essentially having a tube inserted down into your throat to help you breathe during surgery. With awake spine surgery, you typically get some medications through the IV just to relax you, almost like going for a colonoscopy. And then through advanced technology with regards to the local anesthesia that we have available now, we can actually put medications around the back area that can numb up the back for up to 2 or 3 days. And I personally prefer using this type of awake spine surgery, especially for some of my older patients or some of my sicker patients, because the recovery is quite dramatic. They're oftentimes up within minutes after surgery. Most of them never need narcotics for after surgery, and I think it's a really great option. So obviously, not everyone is a candidate for this awake spine surgery, but whenever possible, it's something I certainly try to offer to my patients because the recovery is just it's really dramatic. In terms of some take-home points, most patients with back problems improve with non-surgical treatments, and this usually involves non-opioid pain medications, physical therapy, acupuncture, chiropractic care, or even epidural injections or nerve blocks. In patients who have failed non-surgical treatments and whose symptoms is significantly interfering with their everyday quality of life, then surgery may be considered for these patients. And when surgery is to be considered, the goal is to always go minimally invasive as much as possible because it leads to less complications and faster recovery compared to traditional spine surgery. And that's it. Thank you very much.
All right. Well, thank you, Dr. Ajiboye. That was very interesting. And thank you for sharing examples of those types of patients who may, consider surgery. And it's just very interesting to hear about the awake surgery that you're doing here at Little Company of Mary in Torrance. Well, before we begin our Q&A session, we have a couple of questions for you, our attendees. If you can please answer the poll that you'll see appear on the screen and just give us your feedback on this spine lecture. We would greatly appreciate it. So I'm going to let you go ahead and take a look at those questions, and if you can answer those. And we do have a couple of questions coming in, and I can start to share that with our panel. The first one is, it's about scoliosis, and it's at age 72. What type of treatment would we consider for someone who has scoliosis and it's been flaring up for the past couple of years and causing this person difficulty with walking upright?
So I guess I could take a lead on this question. So scoliosis is a curvature in the spine. So if you're standing in front of someone, and they is essentially shaped like an S shaped or a C shaped, that's what we call scoliosis. There are oftentimes different types of scoliosis. There are some scoliosis that people develop when they're younger, even in the preteen years, but most commonly in the adolescent years. And that's typically something called idiopathic scoliosis, meaning we don't know what causes the scoliosis. We think there might be a genetic reason why people get this scoliosis. The other more common one is something called degenerative scoliosis, which just means it's a type of scoliosis that develops over time due to wear and tear in the spine, especially when the disc, which is those cushions between the bone, start to wear out, especially if it wears out one side or more than the other, over time it will cause a gradual tilt. In patients with this type of scoliosis, because of it's due to wear and tear, these patients will also have a lot of nerve compression to go along with it, and can oftentimes develop a severe sciatica down the legs. And in addition to this, these patients are oftentimes also tilted forward where they can't stand upright. So these patients, we often will try the usual things we talked about, which is medications and therapies and injections. And if it doesn't work and someone is a surgical candidate, we can oftentimes do reconstructive surgery to correct a few things. One, the surgery has to correct the nerve compression, because these patients typically have severe nerve compression, which causes the pain down the leg. And secondly, the next phase of the surgery involves straightening out the spine so someone is no longer crooked, and also helping someone stand better upright so they're not tilting forward. And that's what we'll call a fusion procedure. So it's the surgery for it's typically called a decompression and a fusion. These are complex surgeries, not done by everyone, and it's typically done by scoliosis trained surgeons. But these are some of my, happiest patients. A lot of this, the surgeries, even we can oftentimes do in a minimally invasive fashion as well. And yeah, but that's certainly it's fixable in the right patients and the right candidate.
Excellent. Thank you. Thank you for that great detailed explanation, Dr. Ajiboye. My next question here. Okay, so it's about orthotics, and I don't know what your take is on orthotics in back health and spine health, and in helping to manage that. But I have one attendee who is just asking about orthotics, and on some of it is a little bit around the challenges of getting orthotics for low-income patients, and if we know any process of how to go about getting prescriptions for them. So one is about your take on orthotics, and if you have any suggestions for referral on how to get orthotics for just lower income patients who are non-diabetic.
Yeah, Catrice, I think that I like this question because it really comes down a little bit to the multidisciplinary approach, that we're talking about spine treatment. I think it's a mistake to treat the spine just in isolation, right? So when somebody comes in with, whether it's neck pain, back pain, you really want to look at the entire picture. And occasionally you will see that someone has an imbalance in leg length, or even like some hip problems that could be construed as back pain, right? So it might be masking back pain, but it's actually coming from somewhere else. And so that's why it's important to do a thorough evaluation, first of all, but we have seen patients who came in with very severe hip problems, and it was previously diagnosed or understood as back pain. So we have to take a step back and look into what the real issue is. Similarly, sometimes patients will have the issues with their feet, where some people have like a leg that's shorter, or have like, a hip problem that's leading to a leg being shorter. And so those imbalance can also stress the spine. And so it's important to correct them. For us, in our office, we work closely with our partners, in the medical assistant, with the insurance of the patients to refer them to the most appropriate level of care, in relation to the problems that they have. For shoe orthotics, typically we will rely a lot on the podiatrist, but on occasion the physical therapist can also help out by determining if there's a difference in the length of the legs, or if there's a difficulty with the gait, when the patient is walking, and how they could be best managed. So I don't have like a quick answer as to where to go for like the lower costs. I think it depends a little bit on the insurance status and how we can work around that. But I think more importantly, it's critical to get the correct prosthetics or the correct orthosis to remediate the problem.
Great. Thank you, Dr. Langevin. So my next question is, what is a desiccated disc? Is this a herniated disc that resolved on its own, jelly volume loss? What is the risk of living with a desiccated disc in lumbar spine?
So that's a great question. So a desiccated disc is just a fancy word for what we call a dehydrated disc. Because remember, the disc are those cushions between the bones. As we all get older, it's a natural process of aging. Everyone gets a desiccated disc. That's the same thing that happens in other joints of the body, such as the knee joints, the shoulder joints, the hip joints. Over time, the cushion or the cartilage in these joints will become dehydrated over time. And there have been studies done about this. So there's a very, very famous study done where they went out on the street and found patients who have never had any problems with their back ever before. And in this particular study, they divided the patients into age groups. So the youngest age in that study was 25 to 34, and then it goes up 35 to 44. And what they found was that in the youngest cohort, so in the 25 to 34, about a third of them, about 30% of them, had some elements of either a desiccated disc or a disc bulge. And that number goes up as we all get older. So the higher up you go in the age group, the higher chances of having this. Just because you have a disc bulge or a desiccated disc does not mean you're going to have chronic pain from your back. It's like a skin wrinkle. It's just something that happens over time as we all get older. And just because it's there, it doesn't necessarily mean it's going to give you symptoms.
Thank you. Is RFA good for lower neck pain?
So yeah, so that's a great question. And it comes down to, a little bit what I discussed, to really try to drill down where the pain is coming from, what the root cause of the problem is. All these options that we've discussed, can treat the pain very well. But some are better than others, depending if the pain is originating from a nerve being compressed or if it's a joint, that's inflamed. In the case of RFA, so that stands for radio frequency ablation. And so that's a procedure where typically a pain doctor or anesthesiologist introduces a needle in the neck near a joint. And that needle delivers a small amount of heat to the area. And the role of that heat is to disrupt nerve fibers that control pain. So it destroys a little bit the nerve endings, but it leads to long-lasting pain relief. My approach to this, since there's a small component of destruction related to the procedure, is I typically ask the pain doctors, that they're going to consider doing this procedure, to perform first what we call a block. So that's when they go in the same area they would with a heating needle, but they inject a local anesthetic agent, like a numbing medication, right? So that numbs up the nerve temporarily. Then it recovers. And during that time, the patient can tell us if they feel their pain got substantially better, and if that's the pain that they were complaining of, the pain that's causing their problem. And so if indeed it helps them out, but it's short lasting, then the pain doctor can go back and do the radio frequency ablation. And so that should provide the long lasting benefit. But again, I think it depends a lot on the root cause, like where we think the pain is coming from. So in cases where the joint is inflamed and the arthritis at that level is causing the pain, then yes, it could be a great option.
Okay, thank you. My next question, it says, I've never had any back issues up to this point, but now my back is constantly sore. This person, I'm getting acupuncture now, but the pain has changed, but isn't going away. It's been 4 months now. What would be the next step in terms of additional therapy?
So that's a good question. Ultimately, it depends on what the exact cause of the pain is, right? And this is part of why it's important to do a good, thorough exam and clinical evaluation to figure out the exact source of the pain. In general, acupuncture is it's usually not my first go-to modality in terms of treatments for patients with back pain. Usually some form of anti-inflammatory medication as well as physical therapy. It's usually the go-to. If those things don't work, and you can oftentimes consider acupuncture as a second or third line treatment. But again, ultimately depends on what the exact cause of the pain is. And if this pain is getting worse, it might be a good time to see a healthcare provider for this, so that a good, thorough clinical evaluation can be done, because it's hard to fix something or make something better if you don't know what's causing it. So that'd be my recommendation, is perhaps see a healthcare provider if this is not getting better.
All right, well, thank you. Okay, so at what point do we see a specialist for our neck concerns? Neck pain concerns?
So yeah, so typically, the majority of neck or low back pain spontaneously resolve, right? So like what we discuss in our lectures, the majority of people, if not all people, will at some point in their life experience significant neck pain or back pain. Fortunately, typically it's short-lived, and so the typical recommendation when someone starts to have some back pain or neck pain is to slow down the level of activities and to use some of the modalities that we've discussed that are easy, like anti-inflammatory medication, cold, warm compresses, over the area. Could include some massage therapy and acupuncture if necessary. That if the pain seems to be lasting, or certainly if it gets worse during that time, but if it lasts beyond 2 weeks, that's a good time point that you'll be reaching out to your primary care provider, and then they'll have a close follow-up with you, perhaps prescribing physical therapy for you to try some guided exercise to see if that would help out. And they'll monitor it to see if it's getting worse or if it seems to be improving. And if the pain continues to worsen, or it continues, beyond like a month or two, that's when we would consider more advanced imaging techniques. A magnetic resonance imaging, so like an MRI of the area, so that we can drill down more to the specific location of the pain. And so typically, as you get an MRI, you would also at the same time obtain a referral to see a specialist like us, basically, and then we can discuss further options.
All right. My next question is sort of about location of pain too. It's how do we locate the area of a compressed nerve? For like this example is in degenerative disc disease in C5, 6, 7 with nerve pain, radial nerve pain.
Dr. Langevin, you want to take that?
Absolutely. So that's a great question. It comes down a little bit to, essentially our job, right? So what Dr. Ajiboye and I do in our clinic. And the way we discern exactly, so that the whole success of defining a proper guided therapy for back and neck pain is to get down to the idea of where the pain is originating from. In this question, which nerve is being affected? And the more precise we can answer that question, the better we are at treating it, right? Because we know exactly where the problem is coming from. We know what's causing it. And so what we use is a combination of old medical science to start, meaning a profound, like a thorough history and a precise physical examination. And so we know, for example, which areas of the body are in pain with specific nerves. So all these nerves are typically going to precise location inside the specific fingers, areas of the arm. And so depending on which nerve is affected, the pain is going to be different, in other words. And then similarly, the different muscles are going to be affected. So if one nerve is affected versus another, we'll see specific muscle group affected more than others. So that's one way that we use. Then more advanced, we use the MRI, right? So we look at where we feel there's more compression. We can look at MRIs over time to see, now the pain is new. We have an MRI from a year ago compared to today. Is there something new on the images? And when those modalities are not sufficient, we can ask our colleagues in neurology to do more advanced diagnostic tests. So they can use something called an EMG or a nerve conduction study. And in that test, the neurologist place small electrodes, some of which are stickers, that they place on the arms and the hands. Some electrodes are tiny needles, like acupuncture needles. And then they measure the amount of electricity that travels up and down the nerves. And with that information, it can tell us if they feel first of all, which nerve they feel is more affected. And second of all, where in its pathway it's being affected. Is it being pinched at the spine, in the neck area, or in the extremity? So that's sort of like all the modalities that we use. And then one additional that we can use is we can ask our pain management partners to use an injection, right? So some of steroid injection or some pain medication injection on a specific nerve. And then we check if you're doing better. So basically we do the injection very focally over one nerve, and we check if that treats your pain, if it reproduces the pain management that you would like to have. And if it's good, then you don't need any further treatment. But if the pain comes back, then you have the option of having surgery at that specific location. So again, it's an area where it's important to have a team that we all work together and discuss these cases to make sure we're doing surgery at the right place, and that surgery is the right modality of treatment.
Great. Dr. Ajiboye, you did mention sciatica pain in your talk. So somebody asked, can sciatica pain go away on its own? How long can it last?
So that's a good question. The answer is yes and no in terms of if sciatica pain can go away on its own. It depends on, one, what the cause of this nerve compression that's causing the sciatica is, and two, it can also depend on the severity of the nerve compression. So, for example, in in published research studies in patients with disc herniations, for example, who have nerve compression and sciatica, we know that 90% of people with sciatica or pain from a disc herniation, 90% of people get better within 90 days with non-surgical treatment, right? Non-surgical treatment could involve just waiting it out to allow the inflammation to go down, taking some anti-inflammatory medication to help speed down the process of bringing inflammation down, or doing things like physical therapy, acupuncture, chiropractor, or injections. Obviously, if you have a pretty severe nerve compression, you have spinal instability, there's no guarantee that the sciatica will go away on its own. But for vast majority of people, sciatica will oftentimes resolve on its own without surgery, or usually within 90 days. Obviously, if it persists, we usually recommend obviously seeing someone for evaluation, get an MRI study to figure out the exact cause of the symptoms. But ultimately boils down to figuring out what the diagnosis is in order to make a prediction as to how long the symptoms will last for.
All right, thank you. I'm going to ask a couple more questions. We're getting towards the end of the evening. My next one was for Dr. Ajiboye, and it's regarding the awake surgery. And this person said, I've had awake injections so the surgeon can talk to me to get my feedback, like epidurals, trigger injections, root blocks. When would you recommend awake surgery, or what type of patient would qualify for that?
Sure. So the classic, so awake surgery started initially with patients undergoing what we call lumbar decompressions, or what we call microdiscectomies for disc herniations, or people with stenosis or sciatica from nerve compression. It mostly has to do with the surface area, right? So in an area, that's a smaller area of surgery where your incision for surgery is less than 1 inch, yes, these patients can oftentimes be excellent candidates for it. And a patient with the right body size, the main limiting factor for the awake surgery has to do with the quantity of the numbing medication we're allowed to give someone. In theory, the larger your body size or the larger the area of surgery is, you probably want to stay away from doing the awake surgery because you're just not going to get adequate numbing medication to make the patient comfortable. But the awake surgery can also be done for patients that are undergoing fusion surgeries, where we have to put screws and rods in the spine through small little holes. But again, everyone is different, and everyone has a different pathology or cause of their pain. The factors, again, we take into consideration are the patient size, what the problem is, what kind of surgery is needed, in order to decide if someone is a great candidate for awake spine surgery.
All right, we're going to ask one more question. I apologize if we were unable to get to your question and you have it here in the queue. But my last question is for Dr. Langevin. Neck pain, this is regarding neck pain, and this person has neck pain that increases after a night of sleep. And could that be the wrong pillows, the positioning of sleep, because they're a side sleeper? If you can help comment on that.
Yeah, that's a great question, and it comes down to the multifaceted, nature of pain in the spine, neck pain in particular. The short answer, if it could be due to the pillow, it certainly could. In that the position of the neck during sleep, it can cause compression of different structures. And so, for example, if the patient happens to have a lot of wear and tear of the joints in the spine, sometimes with extreme motion or rotational motion of the neck, especially when you're sleeping, so you're not moving, right? So you're kind of stuck in that area for a period of time. So you can wake up and then the joints can be more inflamed than when you went to bed. And so as you start moving in the morning, the joints are going to feel stiff. So pain that's more prevalent in the morning in any joint is typically related to arthritis, right? So if the patients tell us, like, doc, like my neck pain is a lot worse in the morning, my back pain is terrible in the morning, and as I start walking, then it kind of eases itself. Then you start thinking that it's probably related to arthritis inside those joints. And in those scenarios, then typically physical therapy, exercise therapy, like yoga, like I discussed, swimming are good modalities, right, to get those joints moving. Typically, perhaps like a small session of exercise before bed can help out, like loosening up the joint before you go to bed. Another cause that come to mind would be somebody who wakes up in the morning, they have the neck pain. But it extends down the arm. Then you would be thinking that perhaps there's a nerve that's a pinch. But during the day, the patient is awake, so they stretch, their neck the other way. Same thing with the low back, without even noticing, just because it feels more comfortable. So the nerve is free. But at night, obviously you're unconscious. So then the neck goes the other direction. The nerve is compressed for a period of time, and then it can last long. So occasionally, changing your pillow might make you feel, might make your neck change position so that it hurts less in the morning because it's not compressing the nerve as much, for example. Or we can add additional modality, again, physical therapy. I showed that cervical traction to raise the neck slightly to free up the nerve. So those modalities then would be helpful in that scenario.
Great, thank you. Thank you, Dr. Langevin. Thank you to everybody for taking the time this evening to listen to our lecture, to ask all of these wonderful questions. And a big thank you to both of you, Dr. Langevin and Dr. Ajiboye from our Spine Institute, for taking the time this evening to provide us with all of this great information. We'll be sending out a recording of this presentation to all of our attendees for you to have access to. And we'll also be posting this on our Facebook page for everyone to be able to view and share. You can find us at the Little Company of Mary South Bay on Facebook. And for any additional information or to schedule a physician appointment, you can call our Patient Engagement Center, the 1-888-HEALING. It's posted there in the chat. Thank you again, everybody, and have a wonderful evening.